We are on live, sir.
Okay. Good morning. I'm Dr. Mamoon from New York. It's morning here. I know in the UK it's evening and in Bangladesh it's at the night time. Welcome to our today's PHA scientific session. We have a very interesting topics today: low back pain, how deep to dig for causes. And we have speakers and the panelists. All of them are very distinguished and renowned, respectful. Welcome everyone to our program today. I'd like to introduce our speaker, Dr. Abdullah Jakaria. He's a rheumatologist at Croydon University Hospital, South London. We have Dr. Professor Kazi Tariqul Islam. Everybody knows him. Professor of Medicine, Popular Medical College, Dhaka. We have our respectable Professor Syed Atikul Haq, Rheumatology and Medicine Specialist, Bangabandhu Sheikh Mujib Medical University Hospital. We have Dr. MD Faizul Hassan, Consultant Spinal Neurosurgeon, the Royal Orthopedic Hospital, Birmingham, UK. So I will invite our main speaker, Dr. Abdullah Jakaria, for the topic low back pain, how deep to dig for causes. Dr. Abdullah Jakaria.
Thank you very much, Dr. Mamoon. Thank you for welcoming me to address this very, very emotive, very, very interesting topic. Respected teachers, colleagues, and the audience, good morning, good afternoon, and good evening. I know the 3 continents people are watching this program. I'm going to go to my slides if I can. Let me just try. Here you go. Can you all see this?
Yeah, we can see. Yeah.
Thank you very much. First of all, declaration of interest. Let me just go in there. Let's see if I can move this one. Right. So I haven't received any grant or any fund from anyone. So that's the first thing to say. I'm a part-time rheumatology doctor in Croydon Hospital in South London, and I'm also a family physician, which is known in the USA, and in the UK, it's a family practice like a generalist. So this topic is divided into 2 parts. First part is for the generalist or internist, or whoever is actually not a specialist in rheumatology or orthopedic or MSK medicine. And the second part would be relevant more to the rheumatology services. Let's go into this is what I've just said, how deep to dig. So we know that our patients usually come to us and say, why I'm getting this back pain, doctor, I need to know the causes. So let's start with the first half of the talk. Now, how common is it? So if you look at the literature search, you'll find different data. Overall, this is something I found useful. CDC has done a survey and it shows that non-specific back pain is about around 90%. When we say non-specific, meaning that we don't know what's the cause of the back pain. It could be called as a mechanical back pain, non-specific back pain, or the back pain where the causes are not known, or we call it chronic back pain, whatever the reason is. We don't know. Next one is the cause is known, particularly the area for physician and surgeons. These are vertebral compression fractures where you can have some medical treatment and some surgical treatment. And obviously the prevention is there as well. Metastatic cancer. So as you know, the cancer from prostate, actually, in fact, from any primary cancer can metastasize, but mainly prostate, breast cancer, lung cancer, thyroid cancer, and these are the main one, but also ovarian cancer, melanoma even can metastasize as well. Next one is the emergency one, cauda equina. We must not forget about it. This is something that anybody talk about low back pain must mention about this cauda equina syndrome. And infection. Infection is also common in the South Asian countries or the countries where the TB is common and the IV drug users in the Western world, where the infection needs to be ruled out in low back pain cases. Now, the other causes are very important for us because these are the ones that we need to focus on so that we can rule out causes, like say, for example, what we used to be known as ankylosing spondylitis. Now the new nomenclature would be axSpA, axial spondyloarthropathy, facet joint arthropathy, radiculopathy, spinal stenosis, even the benign sounding osteoarthritis of the spine can cause severe back pain. Spondylolisthesis there, the list goes on, it's pretty long list. So the one that I put at the bottom is actually from the NICE. NICE has quoted this literature from 2013 saying, expert opinion in a review article says, anyone from their lifetime, sorry, can you please mute that? I don't know, I've done it. So the literature says that any one person in their lifetime, at least 60% of the adult population will experience low back pain. So it's very common, and the causes most of the time it's not been actually investigated enough to find out the cause. So let's go into the next slide. So the reason that I'm showing this slide is to show you that there is no big difference in terms of the prevalence between 1990s and 2017. So two different tables, as you can see, but there is a difference between the Western world and say, for example, South Asian or sub-Saharan countries. So in terms of the prevalence, if you look at the high income North America or Western Europe, the percentage is about 12-13%. But if you look at the South Asia, or let's say, for example, Latin American countries, the percentage is about single digits, about 7-8%. And over the period of time, there is no big difference. So that's something to be aware of. Now, medical school slide, I'm so sorry to show you this because I'm not sure we have different types of audience. It could be very simplistic way to say history is the key. If you look at my presentation, the subsequent slides, you will see the history is the key because you can easily direct the patient to do this specific investigation rather than doing all the bloods, all the imaging that in the world. So you tick everything. So history is the key so that we can tailor your investigations. Now in examination, I'm sure we're exhausted with this in medical school to do all sorts of SLR tests, lump test, spine palpation, Walter tragus. Actually, some of those are too late to treat those patients. So say, for example, Walter tragus distance, usually done in inflammatory back pain or neck pain. When the people will develop this, that question mark sign, or people, their Walter tragus distance is more than 10 centimeters, it's too late. We should catch them before that and actually treat them. Modified Schober's, I put in there because that gives you an indication of the back mobility of your lumbar spine, how much they can bend forward. If it is more than 5 centimeters, then it is relevant, and we should do it. So if we can do few examination, that will do. And the investigations I put as a baseline investigation, i.e., the next slide will explain to this, which is to exclude some of the important ones, some of the important diagnoses that we need to rule out. Now, the first, I put on the left-hand side, you can see 5 different steps. So we need to, as a generalist or an internist, we need to make sure when we see any low back pain patient that these are the conditions that we rule out within preferably 2 to 6 weeks time. This is obviously the NICE in the UK suggested, but I think it's a sensible practice that we go one by one and rule them out. Now, so the first one, cancer, very obvious. Primary cancer, if someone presenting to you with a low back pain, first onset after the age of 50, we must rule out myeloma, multiple myeloma, simple as that. First onset, back pain, 50 years plus, rule out myeloma, primary cancer. Secondary, obviously, we should ask whether they had any cancer, think about the metastasis. This is the number one, we should not miss cancer, number one. Next 3, fracture, inflammation, inflammatory back pain, and neurological, i.e. radiculopathy. I'll talk about this in a bit more detail, but the bottom one is obviously rare, very rare, like infection, discitis, and other infection, TB, that needs to be ruled out. When we do basic investigation, we should include ESR, CRP, and obviously chest X-ray and so on, based on investigation, would be able to tell you. And if the patient has fever and other, like losing weight and all, appetite and all those things will indicate as well. So these three in the middle, fracture and injury, so that bit we'll talk about this a little bit more detail. And inflammatory back pain, AxSpA, or what used to be known as in the past ankylosing spondylitis. This term is a little bit less in use because ankylosing spondylitis is the last part of this AxSpA when it will be sclerosed, those SI joint, and you don't want to get to that stage. A neurological one I put, it is basically radiculopathy when the disc herniation or spinal stenosis can cause that, mainly the territory where the endpoint is perhaps with the surgeon. So, but initially the diagnostic part needs to be done by the physician. So next slide, one other thing I wanted to say here on the right-hand side, I put if the back pain is less than 3 months old, then we call it acute back pain. And if it is more than 3 months, chronic back pain. Sometimes it can be acute on chronic. Patient got better, but again it started. So just to be aware of this, and the next slide will tell you a bit more about the how to rule out red flags. Now, these red flags is coined by the Royal College of Emergency Medicine. So when the patient is attending emergency room or A&E in the UK or generalist, we should be all thinking about this tuna fish. And this acronym, if I don't know whether you like acronym or not, I find it useful to remember. But if you don't want to, you're good enough to remember things without any acronym, fair enough. So it's very explanatory. I'm not going to read one by one. We all are very red flags, just to put them in a formal way so that people can remember those things: trauma, weight loss, and so on. So that's that. So just to save time, I'm going to go to the next one. Now, this is a real case which has been published in the BMJ not long ago, during the COVID time, actually. So I was going to read this, but if you could read maybe yourself as well, because there'll be a question after this, and you can think about it, what would be the answer. I haven't been able to prepare any poll. If you can just think in your head, and it will be an invisible poll. So this is a 42-year-old woman presented to an out-of-hours doctor with a 5-day history of low back pain, with burning pain radiating into her right foot. She had a body mass index of 39 and 12-year history of chronic low back pain with intermittent left-sided sciatica pain in her thigh. Now, I'm not going to go and debate about the sciatica and why is it in the thigh. Usually after knee, we call it sciatica. When the pain is up to knee or thigh, we don't call it sciatica. Let's not go into that discussion, but just take it for, as a face value. Left-sided sciatica pain in her thigh. She had noted tingling in her genital area. Genital area is tingling. There was no incontinence. The general practitioner considered on examination that anal tone and perianal sensation were normal, as were power, tone, reflexes, and sensation in the legs. So the examination was essentially normal. The patient was treated with analgesia, given advice to seek review if she developed bilateral sciatica, became incontinent, and developed leg weaknesses. Right. So next one. What do you think that, would you do anything differently with this patient? Just think in your head, 5 seconds, and then we'll come back to it. I'll show you the next slide. I don't have the facility to do the poll now today. Right, so I don't know. I think the doctor has done a reasonable examination, but obviously it didn't go according to the plan, and which is why BMJ has published this and warned doctors, whoever is following the textbook, just to review your practice, that there are certain red herring, shall we say, just a thing that we think we're doing good, but we are not. Next one. So what's the outcome? So this lady, 3 days later, she was admitted with cauda equina syndrome and underwent surgical decompression. She was left with lower limb weakness, numbness of the genitalia, loss of sexual function, and urinary and fecal incontinence. Not a good outcome, is it? No. So what can we do differently? I'm sorry about this busy slide, but it's something that we have to mention those things here. Now, sciatica it's pain or numbness that is usually referred below knee. So when you say sciatica, when you diagnose next time sciatica, all of my colleagues, if the pain is not below the knee, it's unlikely sciatica in terms of as a kind of a correct coding. When you code, I don't know whether you use any electronic coding system. If you do, then it has to be below the knee. In contrast, the non-radicular pain referred to upper posterior thigh. So if it is non-radicular pain, it could be upper thigh. Although bilateral sciatica is classic red flex symptoms for cauda equina syndrome, CES, it is present only in about 50% cases. It is critical to diagnose CES before patient becomes incontinent. When the patient is incontinent, it's too late. Advice to return to the patient becomes incontinent, it's too little, too late. Now, pain inhibition, because we have read in our textbook that, ask about whether the patient is incontinent, anal tone is okay, blah, blah, blah. But actually, in this review, it says when you ask those questions, if they develop these symptoms, then it's too late. Pain inhibition may cause difficulty passing urine. That's true. But then the loss of sensation or the sensation of fullness or disturbance of sensory disturbance around the anal passage, anal urethral sensation, that could be something relevant. So what it means is subjectively, if patient is saying, okay, look, I have problems with my sensation, this carries more value than what you find in your examination when you do anal canal tone assessment by yourself. So the next point, which I can't see because of this, let me just move this cursor. Assessment of anal tone is a poor predictor of cauda equina function because number one is subjective. Number two is you don't know whether this patient is probably not a straight person, maybe a gay person, so the anal tone can be different. And sensation usually, like when you do with the Cottonwool or any test yourself, this carries less value than when patients say that they have disturbance around the perineal area. So that's the last point. Now, it can present acutely. So the cauda equina syndrome, CES, can be acute presentation, like somebody never had any back pain in their life, the first thing in their life. So this is known as type 1. As an endpoint in someone with chronic low back pain, which is known as type 2, and develops slowly over days or even weeks, which is harder to actually diagnose, with gradually progressive saddle numbness, urinary symptoms, which is known as type 3. Some of this, I think I've taken it from the BMJ, which is I find very useful myself. So CS is very rare, some stats there, 1 in 33,000 to 1 in 100,000, which means that as a generalist or internist, you may not see one case in your lifetime, or you may or may not say. If you work in an orthopedic center or MSK center or even a rheumatology practice, you might be able to see more than, or you might see 1 or 2 in your lifetime. So it is, as an orthopedic surgeon, they do operate on them, regional center. I'm sure Faisal will be able to tell us more about the CES rather than me. So they see more than me. Red flags are onset of bilateral. So if it is bilateral numbness or weakness, then it's very, very likely. Onset of any sense of numbness or pins and needles around the anus, known as numb bump, or genitals, carries more value than what you do as an examination. So to take home message. This is the second one. And the third one is alteration of sensation of full bladder, which is also very important. Desire to pass urine, awareness of passing urine. So all of these last 2 points, patient will tell us, so which is again in history rather than what we do as an examination. Now I put this slide together just in order to save time. So we put here, like vast majority of them, non-specific low back pain, when we wouldn't be able to find any cause, which will go into the detail of the inflammatory back pain and osteoporotic fracture later on. But if we can't find anything, they usually get better within 2 to 6 weeks, and we call them non-specific or mechanical back pain. Now, second point we put it here, which is a multidisciplinary approach in the UK. Usually these patients, they go to the MSK center or MSK service where they will have physiotherapy. As a generalist, I don't know whether we are allowed to take question now or we take it later. I can see some hands, but anyway, let's move on. So basically, we treat them with NSAIDs, physio. Now, NICE has said, don't give gabapentinoids tablets like pregabalin or gabapentin, don't give. But in the UK, the practice is they do give. So neuropath, they think it's a neuropathic pain, they do prescribe. And obviously, if the patient is someone who you think that compression is significant through the imaging, they can go for the surgery if it is suitable for surgeries. But thus, a lot of patients will not be keen for surgery or able to do surgery for whatever comorbidities or many other reasons. Now, there is the other option, which is on the right-hand side, our anesthetic colleague, pain management colleague. They do all sorts of injection. As you can see on the right-hand side, if the cause is facet joint, they do facet joint injection on the right-hand side, F1, F2. If there is epidural steroid injection, ESI, they do it in the epidura. Here, I don't know whether you can see my cursor. It may be difficult. On the left-hand side, as you can see on the nerve block, NRB, can be done here to block the nerve. So the agent they do use, from steroid to local anesthetic, so many other things, the combination of those things, it varies from center to center, and they do it under the guidance of imaging fluoroscopy. And there is no anesthetist I know in the UK will do blindly anymore, because they use imaging to pinpoint this and inject. So so NICE has actually criticized and said, look, if you do that, it only gets better only 3 to 6 months. It doesn't last for long. So why do you bother to do it? It's very expensive. And NICE, remember, it's a cost-effective analysis rather than just open-ended analysis. So they do advise the government and the NHS that what type of treatment is cost-effective. So it doesn't mean that you can't have it. There is a private practice in the UK and all over the world. They do use it just for pain relief. And by talking to my anesthetist colleague and pain management team, they think if you give the steroid, that will work against the inflammation and the release of, because what actually happened in disc herniation, there is a lot of inflammatory agents come out, including cytokines. So if you do put steroid, that will reduce the reaction and patient gets better. When you give this pain relief, they will be able to do the physio. And if they do more exercise, they do more reablement practice, they get better gradually. That's the argument they put. So whatever you see in the NICE guidance is not always in the practice. That's what the reason. That's why I'm just putting it on the right side as a kind of a intermediate proposition between conservative treatment and surgery. Next one. What do you do when no cause is found? Actually, you don't do anything. You give adequate pain relief, physio, rehabilitation. That's it. And the vast majority of them gets better. In fact, you can do certain things, which STAR-T questionnaire, which is actually coined by the Keele University, where you can do a questionnaire. If the patient has yellow flags, which means depression or some sort of unhappiness at work or so many other things, they will develop chronic back pain. So I'll not go into that detail. Sorry, it's a bit noisy. So when do you refer to the specialist? Let's go to the next one. Now, whatever we have discussed so far, say, for example, if you have suggested or you find someone who may be something that you think there may be a specific cause, or you don't know what is happening, you haven't done enough investigations and you wanted to dig deeper, then you should refer the patient to the, every country will have a different center. Here in the UK, I've got MSK center, or you can send it to some people refer them to the rheumatologist or MSK center. So when the patient comes here, what they do, they go through the same thing again: history, examination, investigations. So it's actually, so I'm not going to go to all of the specific things, but I'm going to say the center where I work 2 days in a week in Croydon University Hospital in rheumatology unit, what they usually see with the back pain of these 5 conditions I put on the right-hand side: osteoporotic back pain, axial SPA, XPA, PMR, fibromyalgia, and psoriatic arthritis. So I'm not going to go, it's not possible to go all of those 5, just going to discuss first 2. How we are doing with the time. That's 26 minutes. Okay, let's go to the next slide. So XPA. Now, first question, again, poll question. If you can close your eyes and decide which one is the correct answer, I'll give you the answer later. How long does it take to diagnose XPA from onset of the symptom in Europe or in America? Just think about it and, decide which one is your answer. Write it down on a piece of paper. Or if you are very clever, you can go to this paper that I've taken this answer from, Professor Gaffney, who is a very good speaker, and his lectures I'm influenced by. So you can go in there and have a look at the answer if you like to do this when you're listening to that. Now, how common is it? So I'll come into that. Minimum prevalence is actually 1.7 to 3.4% in all chronic low back pain. It's the UK primary care data. Now, XPAR, annual incidence, 6.9 per 100,000 in the UK. Male-female ratio is 3:1. Usually the problem of the younger population. So anybody presenting to you in their 20s or 30s with a stiff, let me just show you all the other features. Anyway, it's all written. Strong genetic association, as you know, 90% Caucasian will have, with AS will have HLA-B27 versus general population will have 6 to 7%. But if they have this XPAR, they'll have 90% will have HLA-B27 positive. Now, XPAR chronic inflammatory condition predominantly affecting spine, but in case of female, that can affect the peripheral joints as well, but mainly spine, SI joints, pain, stiffness, fatigue. If you don't remember anything, if you can remember these three things, pain, stiffness, fatigue. So with or without extraspinal symptoms, so they can have other things like eye symptoms, red eye, uveitis, psoriasis, inflammatory bowel disease, enthesitis, possible. So what is enthesitis? I thought the term it may be useful to describe it a bit more. Used as an inflammation of the tendon when it's inserting, or ligament when it is inserting, or joint capsule insertions. Enthesopathy is a wider meaning, designates all pathological abnormalities of insertions, including inflammatory changes and degenerative problems. So I think there is a fallacy. What is tendinitis? What is tendinopathy? That may be something that we can discuss in another talk, but there is a difference, subtle difference. Let's go into that next one. When to refer? So let's say, for example, you've seen a patient with all these symptoms, stiffness, significant one, younger patient. When to refer? What sort of things that you should look out for? Low back pain less than 35, definitely. Waking up during the second half of the, actually should be 45. I put 35 for some reason, it's a mistake. So waking during second half of the night, buttock pain, improvement with movement. This is critical because if someone's pain improve when they move around, when they start walking, that actually improves their pain, then it is most likely inflammatory back pain. Improvement with NSAID, first degree relative with spondyloarthropathy, current or past enthesitis. Now, this enthesitis can be actually seen in ultrasound scan. So when you do MSK ultrasound, you can actually put the transducer on the heel and you can see enthesitis very clearly. And it can be seen and diagnosed. It's not something like an abstract idea. Psoriasis, IBD, so these are also related to this. And HLA-B27 if you have the opportunity to do the blood test and get the report. Any of the above three, any of these three features, you should refer the patient to the specialist. Now, there are classification now, slightly more, shall we say, it's an evolution really, rather than one day somebody just decided about it. So I'll show you the next few slides. But now what is the current thinking about this is to divide them into two different subtypes. One is radiographic XPAR, another one is non-radiographic XPAR. So primary difference is presence or absence of defined structural changes in sacroiliac joints, right? So what are those? Let's go and see that. Patients with non-radiographic XPAR do not fulfill modified Newark criteria. I'll show you the Newark criteria, which is done quite a while ago, so we'll show you that. But the disease burden and treatment benefit is the same. The reason this line is here is basically to say, look, when it comes to the Newark criteria, it's too late. You need to identify the patient beforehand and treat that. So that's the reason I put it there. Now, in 2017, BSR guidance emphasized and later endorsed that anyone younger than 45, back pain more than 3 months, with stiffness, consider XPAR on the basis of Newark criteria. or ASAS criteria. Now, I'll show you both New York criteria and ASAS. ASAS is Assessment in Spondyloarthritis International Society classification. So I'll show you in the subsequent slides. Well, the last thing is classification versus diagnosis. So some people get confused with the classification criteria, which is for research, and diagnosis. Diagnosis is a clinical criteria. So when you diagnose something, it is mainly depending on your clinical judgment, and the classification is usually done so that you can put them in a different arm of your research. So modified New York criteria classification, ankylosing spondylitis. The name shows you ankylosing spondylitis because it was done in 1984, long time ago. So as you can see, clinical criteria would be, again, the low back pain stiffness more than 3 months, improve with exercise, yield limitation motion lumbar spine in both sagittal frontal plane, which is a modified Schober's test you can do, limitation of chest expansion. Again, you can, this to B and C is an examination. And the radiological criteria, which has been emphasized, that when you get sacroiliitis, grade more than 2 bilaterally or grade 3 to 4 unilaterally. Now, these radiological criteria, when you see the radiological changes in sacroiliac joints, it's too late. It has already damaged it. Okay, it's probably 10 to 12 years in the disease. I'll show you why. Next slide. This is the radiological picture on the right-hand side, and these are the newer criteria. Grade 0, normal spine. As you can see on top left picture of the X-ray, you can see this SI joint very nicely seen. On the next one, you can see grade 2, you can't see much. Grade 3, completely obliterated. Grade 4, it's gone. So it's actually grading system where, you know, and because this has not been used now widely because of the MRI scan is available now. So when you do MRI scan, before you see all those grade 2, 3, 4 changes, 10 years before that, you will see the bone marrow edema. And the radiologists, they're so good, and we are grateful to them because they can identify them 10 years before those changes. So when it becomes ankylosing spondylitis, long time before that, you will see them, the changes will happen in the SI joints. I'll go to the next one, ASAS criteria. So ASAS classification was useful. It was done in 2009, I believe. Yeah, 2009, when it was actually given a very clear instruction to the rheumatologist. Look, whether if you have got an imaging arm, which is on the left-hand side, or clinical arm on the right-hand side, first thing you have to check, do the X-ray. If X-ray is negative, go to the right side, clinical arm. Clinical arm means you do the HLA-B27. If it is positive, follow that. If any criteria, then you can diagnose or classify. Actually, I shouldn't say diagnose. It's actually classify the disease. And these are the SPA features. And as you can see in the red, on the left-hand side, I put it on, sorry. On the left-hand side, as you can see, active inflammation on MRI, highly suggestive of sacroiliitis associated with SPA. So now, these ASAS criteria, if you look at the literature, it will tell you it's good for the classification, but not for the diagnostic criteria. So when you think about the diagnosis, I'll show you how we do this in the UK. Now, this is important because as you can see, SPADE, which is a spondyloarthritis diagnosis evaluation tool. I'm sure we all are aware of what is BASDAI or Bath Ankylosing Spondylitis scoring system. These are the same people who have done this electronically, meaning if you go and Google it, a SPADE tool, you'll find that SPADE tool and put those, like as you can see, inflammatory type back pain, heel pain, peripheral arthritis, dactylitis, iritis, psoriasis. You can put all of those, you tick those boxes and ask for the results, and it will tell you the results. And this is how you can, it's a diagnostic tool. So it's very easy to do that. Anybody can do this. Now, this one, I just wanted to show you how we do the BASDAI scoring system. Now, with this digital world, everyone has got nowadays app. So if you can get an app for this BASDAI score, sorry, got it. BASDAI score, Bath Ankylosing Spondylitis Disease Activity Index. We have to just ask these questions on your right-hand side, and you have to go through these complex calculation, which we don't need to do it anymore, because this BASDAI app is available, and you can just sit with the patient, do all those questions, and it will give you the answer, the score, basically. Now, why BASDAI score is important? Why do I bother to do one of them? because Biosphere score will tell us where the disease is, whether the disease is active or not. So this is what we use in the UK clinics. So you do fill out those like modified Newark criteria, or bone marrow edema in sacroiliac joints on MRI. You say yes, go to the Biosphere score on the left-hand side. If yes, then you consider treatment. What treatment we do? First of all, you use NSAID of two different types. Maybe first you can use the normal non-COX-2 inhibitor first, like naproxen, high dose, good dose. And then if it doesn't work, within 2 weeks trial, if it doesn't work, you go to the COX-2 inhibitor. Eterocoxib seems to be very favorite in our unit. You can choose another type of COX-2 if you like, give the PPI cover, and then use that 2 weeks trial. If it doesn't work, few years back in the UK, we used to use DMARD of some, the old version DMARD. Now we all use biologics, and I'll come to that in a second. So the biologics on the left-hand side, you diagnose it, giving the biologics, life-changing management. If you give biologics, these people, they get better. You stop the inflammation, they get better, get a new life. That's for sure. So on the right-hand side, you've got the other things. If they don't fulfill the criteria, do the HLA-B27. With the HLA-B27 route, you can put them through this same left-hand side flow chart, and you can treat them. If the HLA-B27 also negative, then you think, okay, this person don't have it, don't treat it. Okay, so that's how we do that. I don't know how we're doing. 39 minutes. So I'll be another 6 minutes. I don't know, I may not be able to finish. So biologics, I'm not going to go in detail of these biologics. This is mainly anti-TNF treatment, and there are lots of biologics available. The biosimilar one is available, Remicade, Remsima, and Simponi, and so many others. So, and if this fails as a second line, you can try IL-17. Let's go to the osteoporosis very quickly. Now, we all know what is osteoporosis: brittle bone disease. Bone is weak, bone is thin, it's breaking. What's the science behind it? More osteoclastic activity, less osteoblastic activity. Consequences: thinner bone, breaking bone. So we want to protect this fracture. Typical site: hip, spine, humerus, forearms. We all know that. By the way, this brittle bone disease, when it's happening, it doesn't cause any pain. When fracture happens, then you feel pain. Right? So it's asymptomatic to start with. If you're not looking for it, you will miss it. Primary causes, if it is age-related, and when postmenopausal women develop it, then we call primary osteoporosis. When there's a secondary cause like GIO, which means glucocorticoid-induced osteoporosis, funny enough, some of our patients for RA, lupus, or IBD, they're on steroid, and that can cause osteoporosis. Systemic release of cytokine can cause bone resorption and hypothyroid and so many other causes. So secondary osteoporosis is there. How do we diagnose it? DEXA scan. And obviously, how do we investigate for other causes? I've put some of this suggestion here. You may have extensive workout plan, but obviously I've given some here. What we do normally as a minimum, we do kidney, liver, fasting sugar, celiac screen, thyroid function, calcium, PTH, vitamin D, testosterone if it is a man, and sometimes we do if it is a 50+ patient coming for the back pain and first-time myeloma screen. Bone turnover markers is not done readily, not regularly done. I don't think there will be time to discuss about it. Calcium intake, you can do this calculation. There is the Edinburgh calculator. Assessment of the risk. How do you do that? By doing the BMD, FRAX score, or QRIS. FRAX score is pretty much British thing. Sheffield University professor Akinis has actually first coined this, and now WHO adopted it. Unfortunately, Bangladesh name is not there, but India, Pakistan, Nepal, and all those, Sri Lanka even there. But I don't know why Bangladesh is not there. But this is that for you to look it up. An extra spine is very easy to do. Now, how do you do that? This is a FRAX scoring system. I'm sure you have seen that. This is an online-based calculator. You go and Google FRAX, and you can choose which country you want to put. If you put calculation tool here, if there is a drop-down button here, you can choose your country. So I've chosen UK. What you have done, so this is the lady that I put here, 55-year-old, 70 kilogram, 167 centimeter, and no other risk factors on the left-hand side. only risk factor she has, her alcohol intake is more than 3 units per day. So I put yes there. So when I have put yes, it just gives calculation without any BMD, meaning that I haven't done DEXA scan. So that tells me that this is the risk, major osteoporotic risk and hip fracture risk, but that's not good enough for me to understand whether we should do a BMD like a DEXA scan or not. So there is, as you can see at the bottom, there's a NOG guidance. NOG is the National Osteoporotic Guidance here. So we click that button. What we see next, we see, well, this is just an explanation. You see this. So that's when you know that this patient should do BMD or DEXA scanner. So this is, I was just chatting with Mamun Bhai just a few minutes ago. How do I access different investigations? What's the rationing system? So rationing in the UK is you use this data and you see where it falls. If it falls into the measure BMD, which means DEXA scan, then we should do DEXA scan. There is another way to do this is QRISK. We don't use QRISK, we do FRAX. We use FRAX, but QRISK include a lot more risk factors. I'm just trying to do it very quickly. So once you do that, once you put that BMD, once this patient will have the BMD done, T-score is minus 2.6, then you put it in there, it gives you then a different osteoporotic risk here, 10 years risk. And if you then again hit this view NOG guidance, then it shows you whether you should treat it or not treat it. It's very, very much tool-based service, so that it's an universal, everybody does the same thing rather than what I think is the right thing to do, rather than just whatever you think. So it is actually tool-based service. So if you put that one, you see the hip fracture probability is higher, and it says that you should treat. So we should treat them. So how do you treat that? Or TBS, I'm not going into the trabecular bone score. This is another way to do that. There's no time for this. Let's go for this. Manage to reduce risk. So how do you do that? Now, lifestyle, as we all know, stop smoking, reduce alcohol, calcium, vitamin D, protein intake, falls prevention, and so on. So these are the things goes without saying. Now, how do we treat in terms of the pharmacological point of view? So we need to choose the drug which is most suitable. In the UK, first line is oral bisphosphonate, which is basically what it does. It inhibits osteoclastic activity. Alendronate, zoledronate is IV, actually risdiplam oral, and denosumab also RANG ligand inhibitor. You can use that, which is also injection 6 monthly. So this is something first line oral, and then you can do other injectables one. If it doesn't work, then you can go to the teriparatide, which is actually an anabolic drug. In the UK, you need a special permission, very expensive, 2 years course, it will be approved. And if you do two years of this, usually the patient cohort has been chosen whose T-score is more than 4, or they had 2 fractures or something, and not responded to the bisphosphonates or other treatments. So go to the teriparatide. And both anabolic and anti-resorptive drug, which is a fairly new, just been approved in the America, I think it was done in last year, and in the UK, it is approved actually, romosozumab. It is a monoclonal antibody, 210 milligram per month injection. It comes as actually 105 milligram in an injection, and you have to do 2 injections once a month, which is really very good drug. But then again, we have to apply for the funding. It's not cheap. So the other things are raloxifene can be done, strontium can be done, given, but strontium and raloxifene is not very much popular in the UK. We don't see many people on them. Length of treatment is another question we usually get. How long should we treat them? Once we put them on bisphosphonate, some patients are on them 5, 7, 10, 12, 13, 15 years. When to stop this? So this is another question. So usually the assessment is again by the tool, the FRAX score. The FRAX scoring is important because it tells you what's the risk attached to it. You can go easily up to 10 years. And then after 10 years, you need to think about whether it is adding anything. The main goal is to prevent fracture. And prevention of fracture is not related only to BMD, but also other factors. How this patient is moving around, whether they need any walking aid, they need a visual, their eyesight is good, and lots of other things that you need to look at. Now, this talk will not be complete if I don't say anything about the OMJ, osteonecrosis of the jaw. It is it's a side effect if you use zoledronic acid in high dose. It is used in multiple myeloma and metastatic bone disease, high dose of Zol. Ivizole is something that can cause this problem, but in oral bisphosphonate, it is pretty safe and rare side effect of ONJ. The other one is atypical femur fracture. 47 minutes. How am I doing with the time? It's okay. It's finished now. I was a bit rushing. Sorry. It's just so many things to say.
Thank you, Dr. Jakaria. It's a wonderful presentation. I know it's a lot more things to say, but we have more panelists here. I think they will help us also to learn more. Before going to the panelists, I'll just read a couple of questions. If anyone willing to answer that from the panelists, otherwise we'll go back to our speakers. One question I saw that how we can differentiate between tuberculosis versus cancer malignancy involvement in the spine. And another one, how do we manage pain in patient with renal impairment patient, like dialysis dependent versus independent. Also, recommendation regarding BMD, DEXA, and bisphosphonate in a patient with CKD with osteoporosis. So next, I will come to our very distinguished, respectful teacher and the professor, Dr. Said Atikul Haq, renowned rheumatologist and medicine specialist, Bangabandhu Sheikh Mujib Medical University Hospital. Dr. Atik sir, please, we are looking for your remark on it. Sir, need to unmute yourself.
Okay, thank you very much. I think, I shall address the question. Let me see. Okay, what is the recommendation regarding BMD, DEXA, and bisphosphonate in a patient with CKD with osteoporosis? Just, this is, I am picking up. So for such patients, up to CKD stage 3, that is, EGFR above 30 ml per minute per, 1.73 square meter body surface area. These are stage 3. And it is said that, for up to stage 3, actually the treatment is as like patients without CKD, but we have to biochemically exclude CKD MBD by measuring calcium phosphate, then, IPTH, and also vitamin D. And we have to correct those abnormalities. Then we can give any of the, anti-resorptive drugs as per recommendation. And I very much agree with Dr. Jakaria that, our first line anti-resorptive drug is an oral bisphosphonate, particularly alendronate and risedronate, not ibandronate, that is so frequently prescribed in our country under industry pressure. So, but if the patient is in stage 4 or 5 CKD, then the issue is a bit different. In those cases, firstly, the patient must have a history of fragility fracture and a high risk of death from a fracture. That is one. And CKD MBD must be ruled out. If these things are ruled out, if these requisites are fulfilled, then we should give some, oral bisphosphonate like either alendronate or risedronate. And for CKD5, it is recommended that we must do bone biopsy, not only biochemical exclusion of CKD MBD, but we have to exclude CKD MBD. CKD MBD is also a condition which is characterized by easy, fragility, fracture of the bones, and also changes in the BMD. But, in that case, we can exclude with the help of measuring calcium phosphate, those are things. But in patients with CKD stage 5, we have to do, bone biopsy to exclude CKD MBD. And if CKD MBD is not there, then we may treat the patients with oral bisphosphonate again. Or for this country, actually, CKD, there are some recommendation for zoledronic acid as well. But for patients with CKD stage 4 or 5, oral bisphosphonates are recommended. Thank you very much.
Thank you, sir. So before going to our another overseas expertise, I'll request our another respectable professor and teacher, Professor Qazi Tariqul Islam.
Well, it was wonderful to listen from Jakaria. Professor Atik is my classmate and my friend. I'm internist, but he is rheumatologist purely and pioneer in Bangladesh because rheumatology, musculoskeletal diseases, uh, he is the person actually who started in Bangabandhu Sheikh Mujib Medical University with the help of our renowned teacher, Professor Alam sir. What I will answer, there were some questions. I want to answer one question. Let me take the opportunity to tell how would you how will you differentiate between TB from malignancy when it involves the spines?
Right.
If I tell in a very simple way for the listener as well as for the teachers, for the learner, that one thing you should do, that when you are just doing a lumbosacral spine or dorsal spine, both view, please try to concentrate in two areas. Number one, whether the vertebra is intact or not. If it is intact and the intervertebral space is not intact, and this intervertebral space is rather involved and fused with the two vertebra, it is very easy to differentiate. In case of malignancy or secondaries in the spine is involved, but intervertebral space remain intact. But in TB, the intervertebral space is involved, the spine remain intact. This is the rule of thumb by which one can differentiate. Of course, definitely, if there is any confusion that this does not fit properly, obviously the histopathological approach, and from there you can take the tissue and histopathologically it can be diagnosed, and we are doing it. We are advising it, and this is being done over here. I will tell one or two another associated words not regarding the question. Regarding the use of SARM, nowadays it is in Bangladesh, it is not, we are using Reloxifene and all others. This SARM is not being used because so many other modern drugs are available. As per the description given by Dr. Jakaria, very nicely he has mentioned. I was confused regarding the fracture score. I could not follow his word that he did not see the name of Bangladesh. What does it mean? Because fracture score is practiced by our people, our students, our postgraduate training, even our doctors by Bangladesh. So what he did mean for that, I'm not sure. But we used to do through the Google, and it is being done. The risk assessment score, it is being done. And last but not the least, regarding this low back pain in Bangladesh, in our setup, in internal medicine practice, it's the most common issue in our practicing time. Most common issue. Why I'm telling most common? Let me tell the story in Bengali. যেমন ধরেন আমরা বলি মাঝে মাঝে মিডল ইস্ট সিনড্রোম, এটা আমরা ফান করে বলি। Middle East syndrome means the husband of the woman residing in the Middle East country, not coming to home for last 4-5 years. The women develop so many somatic disorder. Of them, low back pain is one of them. Obviously, this low back pain includes in Bangladesh. You cannot imagine. We have one study that hypovitaminosis D in a remarkable situation, though it should cause the aches and pain of the muscle, but they starts with low back pain. If they squat, they cannot get up because of the back pain. But if we do all the investigation, what Dr. Jakaria told, everything comes normal. if you do the vitamin D level enormously, it comes extremely below low level, like what you know, severe deficient, that means below 10 nanogram per ml. So this was the picture what we face in our country that I told. Thank you very much. I stop here. If there is any situation, I will join again.
Thank you, sir. It's a wonderful differentiation you have mentioned about the radiological finding. Yes, with that, we could definitely always should be careful about a clinical finding, a gold quantiferon, we can check for that also. And next, I will ask our.
Mamun Bhai, can I just say, sir, thank you very much for listening and saying the kind words, both Atik sir and Tariq sir, thank you very much. So what did I mean by this is actually when you go to the FRAX risk assessment tool, which is what you can see. So if you look at the calculation tool, you can see Asia, Europe, Middle East, and all those countries here. So basically, I don't know, there may be ways to find out from Bangladesh, portal. I think the World Wide Web behaves differently when we change our continent. So while I'm sitting here in London, I'm looking at it. So if you look at the Asia part, and if you go onto the right side, you can see China, India, Indonesia, Japan, Kazakhstan, and all those, Nepal, Pakistan, Singapore, and Sri Lanka, and all those. But I couldn't find my country. So that's what I meant by this. I wanted to show you the Bangladeshi perspective.
Sorry, I didn't attack you.
No, sir. That's absolutely fine. It's not. I feel proud to be a Bangladeshi. It's nothing, if you go, I'm always, I'm not thinking about anything negative, but I'm thinking of it may. I don't know why they haven't included us.
Actually, Dr. Zakaria, may I respond to your this confusion? In fact, we had contacted with Professor Kenes for development, for placing Bangladesh, but for this actually, as he replied, and that is also true. I know that for this we require our own data. That is what is the fracture rate, then age-adjusted fracture rates, and also BMD of patients who sustain fracture. We need some a group of information, baseline data, but we don't have any reliable published work on these issues, and that's why we could not include Bangladesh.
I'm going to the next BSR meeting. If I see first, sorry, sir, I was going to say I'm going to the Manchester meeting BSR conference. If I see him, I'll raise that with him.
Okay.
If he's around.
Okay. But actually, these things are genuinely actually required. These data are really required.
Thank you, sir.
So thank you. Actually, the people who are living overseas, always if we see some South Asian country, we are always looking for Bangladesh name also, right? Okay. So next, for our perception in the hospital, for my experience, if any people from Bangladesh coming to me, is low back pain, first thing I ask them, how many years you have this pain? They say 10, 15, 20 years. I'm more happy that, okay, you can live for another 15 years without any problem. But in the hospital, if I see any white people, Caucasian or Afro-American people with the back pain, always is kind of red flag to us, okay? Because, it's all, chorda equine or the cord compression, metastatic disease could be a concern. So next we have, we are really grateful to have Dr. MD Faizul Hasan, consultant spinal neurosurgeon, the Royal Orthopedic Hospital, Birmingham, UK. Dr. Faizul Hasan.
Assalamualaikum all. Thank you for giving me the opportunity. I'll just answer a few topics regarding the surgical perspective of low back pain. It is quite severe and so many people suffer for it. But the main issue of treating low back pain is we don't miss the important diseases so that we don't ignore low back pain. I know it's been going for 10 years, 15 years, but as long as we don't miss any chorda equina, any metastasis or anything structural that can be treated. So that is the main perspective of this one. One thing I like to say that sciatica, it doesn't and I disagree with Jakaria, it doesn't mean it has to be below the knees. You can have sciatic in a posterior thigh. If you had a cord compression at the L1, L2, L2, 3 level, you cannot have, by definition, sciatic radicular pain. The main thing is radicular leg pain, whether it follows a dermatomal distribution or a non-dermatomal distribution. L1 pattern, L2 pattern, L3 pattern, those are above knees. So the term should be used whether you've got any radicular leg pain that follows any dermatomal or a nerve root pattern. The second thing is regarding investigations of low back pain. I know different country has their own limitations and everything, but few of the red flag signs we should be in mind when patient comes to us that we've got a low back pain. Some of them, if the patient has got a history of any cancer previously, they must be investigated in why he has developed back pain. Irrespective to the age of the patient, that must be investigated. Second thing, if the patient has a history of any arthropathy like Angstrom or whatever it is, that must be investigated, whether the patient has developed any spinal instability or not, and that is causing the back pain. Whether the patient is a high-risk patient for infection like an AIDS or immunosuppressive conditions like a long-term prednisolone or any other medication. So those patients must be investigated. Even the back pain might be many years, but gradually deteriorating recently. There are so many surgical causes of back pain. A cauda symptom is extreme age, but again, a sciatic or the radicular leg pain is quite common. With aging population, like a spinal canal stenosis is quite common with a very good surgical outcome. In young people, athletes, like in what you call a spondylolisthesis, when the vertebra slips on the top of each other, they can be present with severe back pain, and that can be surgically treated. But again, I must emphasize that one, the pure mechanical back pain, there's no surgical solution. In old days, about 15 years ago, we used to do a lot of fusion surgery, but that has showed no statistical benefit of treating those patients. There are a few questions regarding the group, that how long should we take a bed rest for a back pain, one should exercise or not. There's two schools of thought. There's no need for any bed rest if you're in back pain. If your pain is so severe, you take rest. That is the principle. If you are in so severe pain, no one advising you to go and run outside and do an exercise. When you got an acute exacerbation of your back pain, take painkillers, take some rest, and then you carry on. But the general rule is that you must remain active as possible. You must not gain weight. You must maintain a healthy lifestyle. So this bed rest for 3 weeks, bed rest for 5 weeks, those are all gone things. So take painkiller, take rest, and be active as possible. In respect to osteoporosis, there's a lot of management of osteoporosis, but normally we see in our practice or any spine surgeon practice with facility fracture and with a lot of back pain. So we can treat those conditions. The Americans are very kind of an aggressive. They started to use fusion, like in putting screws and rods. But in UK, we normally do what you call a vertebroplasty or kyphoplasty, basically more or less the same thing. And if the patient can be presented soon, like within first 3 months or 4 months of the fracture, is still showing edema into the spine, they have a very good outcome putting cement, like doing vertebroplasty and kyphoplasty. So if you see a patient with an positive edema in the MRI scan, please refer them to the either radiologist or the surgeon who is doing vertebroplasty. They have got a very good pain relief following the procedure. And the third comment I will make regarding, Sir has already explained to that one regarding TB and the tumor. The basic principle lies the same. Any infection affects the disc space because that is the avascular plane, and the infection grows into the avascular plane. It might be TB or might be any other infection like a bacterial infection, viral infection. The infection affects the joint. When the vertebral body is involved, it's most likely a tumor. But at the same time, in advanced infection cases, it will affect the vertebral body itself, and vertebra ultimately will collapse. So, but with the advent of MRI scan, and any good radiologist can very confidently can distinguish, no, this is a tumor or this is a tuberculous infection. So again, my kind of request to all the audience that one, we know though we laugh when you see a back pain patient, oh my God, another back pain patient in the clinic. But please don't ignore. Try to think why they have come to you after so many years of back pain. Don't ignore any red flag symptoms and just keep an open mind that no, we need to investigate and try to find the cause of the back pain. Thank you.
Thank you, Dr. Faisal. I will request Dr. Atik sir, if you want to answer another question, the prevalence of joint
Mamun bhai, sorry, just to clarify the terminology. I think what Faiz was saying, I think it got a bit of a mixed up here. So let me just, it's not my terminology of sciatica. So basically, the radicular pain from lumbar 1 to 3, when it comes from, they're not sciatica. So let me just show you this, the definition.
They call it by lumbago, but again, is the radicular leg pain, not sciatica.
Yeah. So what basically is happening, because I think we need to clarify the point for audience, not so much so for us. It's basically, I think when you say sciatica, scientifically, you need to have the sciatic nerve involvement. So if you remember, so the one thing I wanted to just to show you the slide, maybe just found out, here you go. I don't know whether you can see it. So if you look at this is not me. This is nice saying, nice guidance or nice definition of sciatica, if you like, okay? So if you look at it nice, what is it? So sciatica describes radiating leg pain caused by inflammation, compression of the lumbosacral nerve roots from L4, L5. So if you do L1, 2, 3, they don't consider it as a sciatica, okay? So they're specific about this thing. If you say sciatica, it has to be this. Forming the sciatica nerve, the pain can have a sudden blah, blah, blah. Okay, so I just wanted to make sure that's, alternative names for sciatica, radicular pain, blah, lumbar radiculopathy, lumbosacral radicular syndrome, and so on. So when you say this L1 to 3 involvement, you can call it as L1 to 3 radiculopathy. But when you mention, it's a subtle things, you don't have to, don't shoot the,
it get confused the sciatica in a medical book. Well, there's no disease called sciatica, it's pain syndrome. But again, the main thing to tell the patient is to differentiate between the mechanical midline back pain versus radicular leg pain. What they call it sciatica, sciatic, whatever it is. But the main thing is that to distinguish between the mechanical midline back pain to the radicular leg symptoms according to the specific dermatomal distribution.
Yeah, absolutely true.
If you don't mind, Dr. Jakaria, both of you are talking same, but to me, the language is different. When we were medical student in 70s, 74, 5, our teacher used to tell lumbago sciatica syndrome. At that time, there was no such clarification, this, that. What the surgeon is telling, he is also right, and you are also telling, you are also right. You are talking same. Up to 3, it is lumbago, and below 3, it is sciatica. I think for our listener, it will be easy to understand. Okay. Mamun, I think I interfered. Just
no, it's okay, sir.
There's no debate. There's no debate.
Right. So I think we are almost running out of time. I have 2 questions to our 2 respectable teachers. Then we can conclude our meeting today. First question to Dr. Atik sir regarding the jaw necrosis, the prevalence of jaw necrosis and femur fracture for bisphosphonate treatment. And another question to Dr. Tariq sir after that, and you can conclude the meeting regarding it's also, from our experience, we saw that I will say 95% Bangladeshi patient, whatever we see here, everyone has the low vitamin D. So what's the reason for hypovitamin D level in Bangladeshi community, or is it in a genetic predisposition, or it doesn't matter, it's from the farming or in a rural or urban area, it doesn't matter. Everyone has very low vitamin D. Dr. Atik sir.
Okay, thank you very much. The prevalence of osteonecrosis of the jaws in the users of bisphosphonate. The global rate, I don't mean, we don't have data from Bangladesh. It is said to vary from 0.7 to 12%. And regarding the, atypical femoral fracture, it is much, rarer. It occurs in 3 to 50 per 100,000 patients using bisphosphonates. This is the prevalence. And, I just, before Tariq replies to the question placed to him, Tariq is my friend, I would point out, one thing, that in our country, in many laboratories, when we ask to assay vitamin D, the laboratories do only vitamin D2 or vitamin D3. What is required basically combined total vitamin D, that means D2 plus D3. Actually, Tariq is, practicing in Popular. Actually, in Popular, I had persuaded, possibly in the year 2013, to change, and Popular has accordingly changed. Now they are giving total vitamin D. Also in other centers where I could influence, they're measuring total vitamin D, but in many centers only vitamin D2 is measured. And actually it is low. That's true that the vitamin D level is said to be lowest in South Asia. But in our assessment, in our country, in the laboratories, of course, the laboratories don't use the appropriate methods. For example, for vitamin D, high performance liquid chromatography and tandem mass spectroscopy. These are the two methods that are recommended. But in our country, these facilities are not available in most of the laboratories. Okay, thank you very much. Now I hand over to Tariq.
Well, Atiq, thank you very much. Actually, I had the opportunity to do a survey of 1,100 doctors with the help of a pharmaceutical supported. They have the vitamin B supplement, so they came forward to do this because if you do D2, it is almost Bangladeshi currency 3,000 taka, and do D2 and D3, it is almost 5,000. What Atiq was telling. It is before COVID, we did it from different parts of Bangladesh, like 8 old medical college. We have seen among the doctors, irrespective of the sex, male, female, no matter, among the doctors, it is almost 68% doctors, they are either insufficient, deficient at different level. And the paper has been published. You can ask why in Bangladesh, as you, Mamun, you are asking. It is a global epidemic. Though it is not crippling people, this is a global epidemic. If you go through online, you will see, starting from north to south, east to west, every parts of the world. And Bangladesh is not out of that. Even in India, in pregnant women, almost it is 82% pregnant women, they are deficient in vitamin D. And I think in 24th Davidson, if you open, you will see regarding vitamin D, there is clear cut. They have included in the textbook that it is deficient in the Southeast Asia as well as in the globe, and supplementation should be given. The reason, mostly, it is we are not being exposed to sun. Only 30% is being supplemented by food, that is egg, butter, cheese, and so many other foods. 70% is coming through this skin when you are exposed to ultraviolet ray, B ray, not other. Ultraviolet B ray is available from 9:30 to 2:30 or 3 p.m. After that, it will not. Before that, it will not. So this is very vital. And at that time, we are in the car, we are going to the office, we are not exposed to the sun. It is very natural. Your kids, I was telling when I was giving a lecture on vitamin D, why the North American people or the European, they are running to the sea beach when there is sun after snowfall or after rain, because they did not get the sun. Even sometimes they don't see sun for weeks together. Whenever there is sun, they do go for tanning, sunburn, and to improve naturally from the skin, argocholecalciferol, and so on, so on, so on. This, all of you are doctor, you know this. And in our country, it is not in our country. In the whole Southeast Asian region, this is an epidemic, you can say. I went to Sri Lanka. Moreover, black pigmentation of the skin that do not allow the ultraviolet B ray sufficient than that of an white one. White people are lucky that if they tan, they will develop the vitamin D much better than a black Negro or a brown color people. And obese, where there is this vitamin D is being sequestrated in the fatty tissues. So many factors are there. I think we are not out of that. And obviously, if we could do D2 and D3 together, what Atik was telling, though it is costly, sometimes we do. But before I conclude, I will tell just a small story. One executive, he's a banker, I think. If it is 3-4 years back, 5 years back, he came to my chamber and he said, I cannot stand up even from the commode to my room after having my wash in the bathroom. Then I said, why? What happened? You got any trauma or anything? He said, no, sir. If I sit down for any reason, I used to ask somebody to get me up. When I did the other investigation, 1 or 2, but it strikes my mind. I did the vitamin D level and it came only 5.6. This is a story I can remember because that man and the whole family, they used to come with other people, whether they are suffering or like that. So whenever we see some rich people, they do not expose to sun in any time, it is better to suspect that they are suffering. They are suffering from hypovitaminemic. Thank you. I'm closing here.
Okay, thank you, sir. I saw Chandan Mitra, he's our coordinator in this side. So Chandan is here. Before going to Chandan, I saw Dr. Arshadul Amin has some question. If you want to open up your mic, you can ask a question.
Hello.
Hello, Assalamualaikum. I'm the wife of Dr. Arshadul Amin. I'm a dentist. I'm a practicing dentist in Royal Free Hospital. So the reason I'm interested, because I'm the sufferer of the back pain as well. So I just watching that, But when you mentioned about the MRONJ, I just become a bit curious because I'm a dentist, but I practice in the Oral Max Fax in Royal Free Hospital. We get lots of patients with MRONJ, and getting it from the oral bisphosphonate or IV form, or sometimes in denosumab for multiple myeloma or other bony conditions. So the thing is that once they get the MRONJ, it is really difficult to offer the dental treatment, and we are keeping a record, and basically we are having a drug trial. Sometimes we give a low dose of doxycycline together with vitamin E, and we also follow in our hospital, we follow our own scoring system. So if you are interested, I can share that one with Zakaria, and possibly you can, if you are interested. I don't know whether there is anything from our American side, whether there is any trial going on, but as a lady, if you ask me to get the IV bisphosphonate or denosumab for myself or for my mom or for my near and dear ones, I'll be very reluctant because I have seen the people, the way they suffer. So
I don't know
that's an
whether
opinion. Basically, it's not an answer or anything because
Okay,
I
okay,
don't think.
understand. Your question will be answered by Sir Atikul Haq regarding this. But as because you are working in Royal Free, this is just a personal. I could not restrain myself. My son is working in the Royal Free in the Department of Medicine. He is a chief register. His name starts with Kazi because I am Kazi.
Okay, it's
Kazi
good to know.
Tamjid. I will be happy. I will tell him to contact you. I
Yeah.
think this will be answered by Syed Atikul.
Okay. Assalamu alaikum, sir.
Walaikum assalam. In fact, I would say this osteonecrosis of the jaw is not very common. Firstly, as I said, the prevalence is only 0.7 to some 12%. And moreover, there are some ways to prevent osteonecrosis of the jaw. For example, we have to cure dental diseases first before starting bisphosphonates. We often forget to do that. If the patient has got any dental disease that must be treated, the patient should observe the dental hygiene very meticulously. That is also another, because patients with poor dental hygiene commonly get this ONJ. And finally, why this Frax threshold is used. The use of Frax threshold is to ensure that, the potential of benefit exceeds the, potential of risk. That is the main thing. So if you are a genuine candidate for this bisphosphonate, for example, your 10-year probability of fracture, hip fracture is exceeding 3%, and 10-year risk of major osteoporotic fracture is exceeding 20%, then you are at a greater risk. And treatment with bisphosphonates, with its cost and with its side effects, risk of side effects, everything, the treatment is justified. So I think, you should not be apprehensive for yourself or your mother or anyone, your kids, that, if they fulfill the criteria, selection criteria for bisphosphonate, I think you should continue, but you should at the same time follow all the measures that are suggested for prevention of ONJ.
Thank you,
Absolutely.
sir.
I totally agree. Just so for your information, I have a couple of slides I haven't showed because I was rushing and trying to finish this off. So with the ONJ, I did an audit while I was working in St. Bart's. So we had about 400 patients on Ivizole. At that time, we used to use Ivizole a lot. So it's actually the prevalence of this ONJ is not that common, but it's not common in our unit for osteoporosis. But people who use, let's say, for example, we use only 5 milligrams Ivizole acid over a period of 12 months. This is a 12 months IV dose. But if you have multiple myeloma or metastatic bone disease, where you use 3 to 4 milligrams every month, the dosing is very high. So in terms of the advice that we give, if you need any dental work like extraction, do it before you go for the treatment. And the window is 8 weeks. So we get regularly dental letters and a MaxFlex letter saying that, what do you advise? The patient is already on bisphosphonate. So if they are on oral bisphosphonate, sorry, sir, I'm just taking a bit more time. I know it's a practical question. So if you're on oral bisphosphonate, there is no need to stop. But if you are on IV or planning to go into IV, so most of our elderly people, thankfully, they don't have any teeth of their own. So that's good. Thank you. That's brilliant. So what you need to do is actually give them IV, no issue. I totally agree with Atik sir. It's actually very safe. And in terms of it's a horrible disease, of course, if it happens, the treatment is very difficult. And you have to take out the dead bones, and it's the mucous membrane is not going to come and cover it. That's the problem. And this is the critical thing. And I got to give this antibiotic, and pain is horrible. So it's a very bad outcome. So we got to be careful, case selection, and also dental work. You need to give a window of that time so that it doesn't really, fall into that time. And most, likely osteoporotic patients, mainly in our unit, is usually 60 plus. I don't see anyone below 50. Very rarely we see. early menopause or something. So I'll just stop here. I know there is no time. I'm looking at Mamun Bhai maybe getting angry with me, this, but I'm just going to stop
Thank
here.
you.
Thank you.
Yeah,
Thank you.
okay. Okay, thank you. I think we had enough discussion, and for other question, you can email us. You can email our admin for PHA, so we will return you. Thanks, Chandan and Dr. Shaukat. If do you want to mention anything, or we can conclude?
No, very quickly. Special thanks to all the excellent presenter from east to west. It was very nice and enjoyable talk. Regarding just vitamin D, I think the other professor from Bangladesh has mentioned, I think it's endemic everywhere in the world. Even over here, I work in general practice in London, so we see plenty of patients. Even from the street, if you gather 100 people and do a vitamin D, 80–90% would be low. So nowadays we stop doing it. So if we know the patient's baseline calcium is okay, what I do, and for other patients and relatives, I advise everybody, especially in the UK, to take vitamin D for at least 8 months from September to March. So the level becomes, slightly on the normal line. Otherwise, everybody is vitamin D, and the effect of the vitamin D is long-standing. And even in spite of here, the food is very regulated. So in cereals, everything, they put fortified vitamin D, but still, I think for best, even in Bangladesh, I would advise, especially in the winter time, at least take some vitamin D. And the good thing is that with pregnancy now, we advise to take vitamin D and calcium, which helps the pregnant mother. Thank you very much.
Okay, thank you. I think that could be another topic, just itself, the vitamin D. So thank you, Dr. Jakaria, for the wonderful presentation. Thank you, everyone from east to west you have mentioned. And thank you, Planetaria, for arranging this session. Good night.
Thank you very much.
Thank you. Thank you. Assalamu alaikum, everyone.